We will now move on to the impact of CML on pregnancy and fertility topic. And it's my very great pleasure to introduce our international expert in pregnancy today, Professor Gianantonio Rosti from Italy. Gianantonio is preceded by his reputation. He's widely known and highly respected around the globe, and we are very lucky in the foundation to have him give so much of his time and knowledge to us. As of 2021, he is a senior scientist at the scientific direction of the IRCCS, IRST, the Dino Amadori in Meldola in Italy. It's an honor to share the platform with you today. Gianantonio, welcome.
Thank you. Welcome very much.
Our fourth and final expert for today is another regional giant in the CML field. We have Professor Zeba Aziz from Pakistan. Zeba is Professor of Oncology at the Hameed Latif Hospital in Lahore, and she is very much my go-to person as a source of knowledge for what's going on and who to talk to about any aspect of CML in Pakistan and the region in general. Welcome, Zeba. It's such a pleasure and a privilege to have you here today.
Thank you, Ali. Thank you for inviting me to talk about this very important topic, which is particularly close to my heart, because we have a lot of younger patients and a lot of them are females, who have a lot of pressure on getting pregnant. So we have to talk about the mother, the baby, and the disease itself. The safety of TKIs in pregnancies has not been established. However, what has been seen is that TKIs can significantly increase the risk of congenital birth defects, and abnormalities include horseshoe kidneys, twisting, and fusion of the bones with the spine. The prevalence of congenital defects from birth registries are 2.78. The challenges which we face in our part of the world is irregular or no molecular testing, and late information from the patients about conception. Since we had a lot of patients and we had a lot of pregnant women coming after they had delivered or late in the pregnancy, we decided to look at our data in Pakistan and see what was happening in our department. This is Jinnah Hospital, Allama Iqbal Medical College. We found that the median age of women who wanted to get pregnant was 30. The fertility and desire to have children are common in all of our population, and the pressures of conception include that the patient is nulliparous, there's illiteracy, and there's nothing better to do than have children. The stigma of infertility affects the woman, resulting in a divorce or separation, and patients tend to wear loose clothes in our part of the country, and we hide the pregnancies. And the last and most important thing was that the women and their families were scared that if they divulge that they are pregnant, they will lose access to the ACCESS program. So what are the recommendations for TKI during pregnancy is that ideally they should be stopped at the first 4 or 5 weeks of being pregnant, when the kid is formed, baby is formed, and is trying to hold on to a placenta. And subsequently, there are lots of data on use of TKIs in second and third trimester of pregnancy. Once we started looking at these things, we found a lot of information, and we decided to write an article of pregnancy outcomes in chronic myeloid leukemia. Now, this is what happened is that we were initially treating all our patients with imatinib, and that was the most common drug which we were using. And then we published a short report from us. Limited information is available on the potential impact at that time of imatinib and fetus. And due to lack of insufficient information, contraception is advised. The mother needs optimal therapy. However, the fetus is affected by the disease. We don't know whether it is affected by the disease and what is the teratogenicity of the TKIs on this. So we had 809 patients, and we could track a record of 21 female patients who conceived on therapy with imatinib, 18 in chronic phase and 3 in accelerated phase. 28 pregnancies in these women were recorded, and the median time to imatinib exposure was 3 years. The fetal exposure was 26 weeks. Treatment discontinuation was only in 10 patients because they reported pregnancy in the first trimester. Now, this is the epidemiological data and the number of conceptions. One woman had 3 conceptions. Every time she would not tell us, and she would get pregnant, hide the pregnancy, and then tell us in the end that this is what is happening. So then we looked at the discontinuation in the first trimester, second trimester, pregnancy outcomes, abortions, induced spontaneous abortions, full-term babies were delivered, 18 pregnancies. Some of them were stillbirths and a couple were premature. 15 were males and 5 were females. Alive up till date are 16, and all kids are normal. It's not female kids, all kids are normal. It's just a error. So in chronic phase, we had 18 patients and accelerated phase 3. The dose of imatinib which they were taking was anywhere from 400 to 800. All the 21 patients had complete hematologic response. They were doing well, and that is why they thought that pregnancy was ideal at this time. However, the complete cytogenetic response was seen only in 10 patients. Partial was seen in 6, while 5 patients had minimal or no response. These are the cytogenetic responses in patients who discontinued imatinib. One patient lost her complete cytogenetic response. And I'm only talking about cytogenetic responses because at that time we were not performing molecular testing. It is earlier on. And this is how we managed our patients. Patients who did not discontinue imatinib, after pregnancy, complete cytogenetic response was seen in 5 versus 3 before the pregnancy. Excuse me. So we concluded that the spontaneous abortion rate in our patients was 5.6 versus 2.9 in the general population. The stillbirths were similar, and pregnancy occurred with frequent in our population. Pregnancies was continued because of precious pregnancies, family pressures, social issues, access program limitations, and religion. Now, we did not see as many fetal abnormalities as is being projected. I think, I cannot say, but I think it's because our patients are much younger and they have less problems with their fetus. Now, here's the first case I would like to present. So this is a 33-year-old female who was diagnosed with chronic myeloid leukemia in 2020. She was put on imatinib 400 milligrams and was lost to follow-up. She returned in 2022 with blast crisis, which had transformed into Philadelphia positive ALL. She received 3 cycles of hyper-CVAD, and we had a ponatinib access program, which we put her on it. Post cycle, she achieved a major molecular response. She came to us 8 weeks pregnant, and she had a male child in her uterus. She refuses to abort her baby, and we have currently stopped ponatinib. These are our questions. We are currently planning to keep her off TKIs and monitor her molecular response by RQ-PCR. Since she's a high-risk patient for relapse, should interferon be added to maintain her MMR? Should we switch ponatinib to imatinib if she loses her MMR during pregnancy? And is there a certain level of molecular and cytogenetic response that is lost when TKI is restarted?
That is a very interesting case, a tough case, of course, but I did some comment to the previous part of the presentation of Zeba, and just as far as, for instance, to the spontaneous abortion rate, which is 5.6% in your experience and 3% around in the general population. But it is considered that in this highly monitored population of patients, all abortions are recorded. This is not exactly the same in the general population, where some early abortion during the first 8 weeks are lost to the and not recruited. And I see that the big difference in your experience is the young age population of your patient. The known event of patients taking TKI and conceiving is related to Western countries where the median age of those conceived patients was much higher, so 10, 15 years. And this, of course, makes a difference in terms of incidence of neonatal birth defects, because if the mean as an average is less than 3% in the general population, there is a strong age effect. So you had, I can comment, good results in terms of either pregnancy termination and maintaining the responses at the end of pregnancy. Even, I mean, in those patients who discontinue or not. The interesting variable is that the median time on imatinib was 4 years. So in a way, stable response with, they were sensitive to imatinib, and it may happen frequently that in a patient with long-lasting imatinib treatment, stopping imatinib is not transformed rapidly into a loss of response. And the kinetic is sometimes slow motion one. So you have time to carry to the end of pregnancy and eventually to restart. But coming to this case is, I mean, is a case with an advanced disease. She received, and the question is, planning to keep off the KI and monitor. Yes, I totally agree. Even if, just in case of, we should not forget that imatinib, after the placental barrier is completed, is passing through the placental barrier at a very, very low level. So some imatinib can reasonably reach the baby, but I mean the consequences are not expected to be, I mean, so huge. But of course, using the imatinib after the 3rd month, just in case of an emergency situation. The question about interferon, now the clone of interest is an acute lymphoblastic clone, and in this situation, interferon probably is not strongly recommended. We remember from the past that in those patients sensitive to interferon was used to maintain the response even in acute lymphoblastic leukemia. But interferon is a slow motion drug, and you need weeks, if not months, to establish a biological effect of interferon. So my answer is not a mistake, of course, but I'm not, I mean, so excited to use interferon, at least in this particular situation. If the patient is losing NMR during pregnancy, my recommendation is just to continue to monitor, because if during pregnancy, now she should be around 4 months on pregnancy, more or less. So for what I said before, the kinetic of losing the response is generally not so, I mean, tremendously rapid. And I would suggest to monitor the complete hematological response, and just if the complete hematological response is lost, to start imatinib during pregnancy. But I believe that in this case, we have, I hope good probability to keep the response. You know that she has basically an ALL, so a loss of response that is, I mean, quite possible, would be a disaster, because now she's an acute leukemia patient. You gave a proper treatment, Ivercivard with ponatinib, and I of course strongly recommend to start ponatinib after pregnancy. Probably number 4, I answered already. So my perception is that that being a acute leukemia patient, you monitor the maintenance of a complete hematological response, because if the response is lost and as acute lymphoblastic leukemia features, then probably a TKI is not enough. But under an emergency situation, so a rapid loss of response, the priority is to try to save the baby and to keep the mother in a sort of equilibrium, but terminating the pregnancy and then deciding what to do. That in this case, of course, is a scare problem, because resistant to a good, a complex polychemotherapy scheme plus ponatinib, and then the chance of a long-term survival in case of an early relapse are obviously dismal. This is, I mean, what I felt to say about this particular case of a young female. Yes.
Can I go to this?
Would you like to make a final comment on this case, Zeba, before you move on to your next case?
Yeah, the patient is still persistent about keeping the baby, and we did a detailed ultrasound of the baby to look at any congenital abnormalities, because she had received chemotherapy, she was on ponatinib. The baby seems to be fine. There are no congenital abnormalities seen on the ultrasound. That made the parents more determined to keep the baby, because a male child, for a 33-year-old female who's scared that she'll not be, she wants her DNA in this world, a DNA imprint.
No, I believe that if the current monitoring of pregnancy is good, I mean, from the echographic point of view, everything is moving on fine. I mean, the fear that I have, being the mother young, is not on the risk of the fetal abnormality, of course, because I mean, should be below 2 or 3% or around what expected in the general population, because when a TKI is exerting its therapeutic effect, all is done during the first 8 or 12 weeks. So now we are beyond 8 weeks, 12 weeks, and the growth of the baby from the echographic point of view is normal. So, of course, our fear is all on the maintenance of the complete remission.
I have one question.
Yes, Zeba, please go on.
I have one question. I couldn't find any data on ponatinib in pregnancy, because usually it's used in acute leukemia. The thing was that, is there any effect on the blood vessels, fetal supply, or any blood vessels in the fetus? And what is the, how much is absorbed from the placenta? I just couldn't find anything to sort of decide what to do with her.
So this is a young female, 33 years old. So I suspect that she is a low cardiovascular risk score, most probably, because probably not smoking, probably she is not obese, no problem with diabetes or other known risk factors for ponatinib cardiovascular event. And so
can it happen to the baby? Can it happen to the fetus, the cardiovascular, like, will there be any abnormalities in the blood vessels, or I don't know. I couldn't find anything. So that's why I'm asking you. As
we have data about the other TKIs, including bosutinib, ponatinib, and nilotinib, their propensity to pass through the placental barrier. And limited data we have is that some low level of TKI may pass the placenta. So this may be true even for ponatinib, but I believe that my expectation is that, ponatinib on the baby's vessel trees is not exerting any particular effect, even because the duration of exposures is very, very, very short. But Zeba, I agree with you that we have no specific data about ponatinib. Even because during all the development of ponatinib, patients receive the drug when they, in the Western world, when they failed 2, 3, or 4 drugs. So all of them, males and females, were far above 50 years of age. And so the issue of an unplanned pregnancy on a female taking ponatinib was consequently very, very infrequent, and no one is honestly resisted. But similar to the experience with all other TKIs, since the molecular weight is not so different from the one of others. So, once more, some TKI, very low level, can pass through the placental barrier, but the placental barrier is a reliable wall for any drug of the same molecular weight of TKI. They should be trapped and not, and so not reaching the baby, at least in a reasonable amount.
A few questions coming through, and we're running short on time for this case. I will invite Dr. Marine Ali Khan to ask her question, and then after a comment, we'll move on to the next case, but other questions can come after the next case. Marine?
There is the question, are TKIs found in mother's milk? Generally, yes, and there is experience particularly with imatinib, but once more, very, very low level, but whenever possible to avoid breastfeeding for this reason. Probably an excess of safety, but whenever possible, this can be avoided.
Marine?
Thank you very much, Arlene, for giving me this opportunity to speak. Thank you very much, Professor Zeba Aziz, my great teacher, for such a comprehensive presentation of a very common problem, that is pregnancy in CML patients. I would just like Professor Zeba and Professor to comment upon my thoughts. So this patient, 33 years old, CML and lymphoid blast crisis, given 3 cycles of hyper-CVAD, if she has pregnancy and a successful outcome of pregnancy without interferon, if the counts are stable, I would not advise interferon. If the counts start rising, yes, interferon can bridge the pregnancy. And recently I had a case last year of CML in myeloid blast crisis, in remission, had a pregnancy without interferon, and after the delivery of the baby, we transplanted that patient with 26% IS PCR BCR-ABL. So this patient would remain a candidate for allogenic bone marrow transplant because she has been diagnosed as lymphoid blast crisis. So what are your thoughts about it after the delivery of the baby, hopefully a successful pregnancy and healthy baby? Thank you. I just wanted to have opinion regarding allogenic transplant, either fully matched or haplomatched, whatever the donor would be available. Thank you.
Zeba, and then Gianantonio, and then on to Zeba's second case, please.
Okay, I just feel that an allogenic, if she has she continues to have a molecular response, I wouldn't transplant her right now and put her back on ponatinib once she once she delivers and wait till she relapses and then see what happens. Because right now the data on ponatinib is very strong as maintenance. So let's see what the next 4 months bring for her and then put her on ponatinib. The other question I wanted to put forward was that should we deliver her at 36 weeks? 34?
Zeba, sorry to
Yeah.
interrupt you. No, I agree with the efficacy of ponatinib, but we should be sure that this lady will gain a deep molecular response as a complete molecular response. If achieving a complete molecular response, then potentially allogeneic transplantation can be avoided. So it is a tough decision, but we need to have a complete molecular response.
I totally agree. I totally agree with you. But I would like to delay it so that she can enjoy her baby.
Yeah,
for which she's worked so hard to get away from this world.
Oh my God, Zeba, this is really a terrific decision. But okay, I support. I mean,
it has to be done with the family. I can't make this decision. But should we deliver the baby early in order to put her back on TKIs?
Wow, is the first baby she has, right? Is the first?
Yeah.
Is the first pregnancy. So with the first pregnancy, if obstetricians, they say that approaching to 7-8 months, and the baby is fully formed, I say, why not? So we avoid eventually potential complication of the physiologic delivery, so anticipating and then taking care of the patient disease. Yes, absolutely, absolutely agree.
Okay, thank you.
So many important social and cultural considerations as well as medical ones. A great discussion. I'm so sorry to do this. We need to move on to your second case, or we will run out of time. So Zeba, please move on. General questions, bring them in now, please.
A 35-year-old female with chronic phase CML was diagnosed in 2018. Her so-called score was an intermediate risk. She was started on nilotinib with a view of achieving a TFR. I thought she'd get pregnant around 38, 39. Unfortunately, at 3 years, her RQ-PCR was 0.1%. She wants to conceive as her husband and family are insistent, and she wants to stop nilotinib. How should we proceed further? Should we give her another TKI before trying for conception, and if so, duration? Is there a washout period for TKIs before she attempts conception? Role of interferon while trying to get pregnant, and should we get help from the IVF clinic for early conception?
So Zeba, starting from number 3, washout.
Okay.
The simple is roughly after 10 days with terminal, pharmacodynamic terminal atomic evaluation. No more drug, no more TKI is kept in the body of the patient. So okay. 10 days, they are enough.
Okay.
This is, I mean, a particular case because 7 years of on nilotinib. So the time of treatment is very long, but the last RQ-PCR was 0.1%. First of all, I believe that this lady has a deeper response. Why I'm saying that? Because 7 years on nilotinib, if adherence was good, maybe that the original transcript was a B2A2 or a A13A2. You don't remember?
I'm sorry, I don't remember. I looked at the so-called score and wrote it down, but you didn't ask me about that.
No, because I mean,
I'm sorry.
This is a fascinating story that those with the shorter transcript, But this is most probably for a technical limit of RT-qPCR, which is waiting more the shorter transcript with respect to the longer one. So this may be one of the reasons to retrieve information about the transcript type and to repeat, if possible, an RT-qPCR. But with if even in simple major molecular response, the chance of this lady of remain stable and eventually to maintain the major molecular response in the long term or medium long term is not so, I mean, impossible. So she's very young. You may proceed probably one, repeat an RT-qPCR and looking at the type of transcript just to understand what's going on. And then after that, this is totally experimental, but to understand it, stopping a TKI and not giving meaning permission to look for a pregnancy, to see in the first 3 months what is going on from the hematological and from at the response level. In other words, totally experimental because it is a planned pregnancy, but if after 2-3 months the molecular level is still stable at that level, we are not totally sure that this will remain the same in the medium long term, but it's already a good period of time. You know that if you stop a TKI, either in deep molecular response, but even in major molecular response, the rapidity of losing the response is not so rapid. From this point of view, there is then I can send you even this slide. It was a trial published, in Lancet Hematology in 2019. The trial is called Destiny. The first author is Clark, but even Jane Appley was on board. And of those 49 patients who discontinued when in major molecular response, 40% of them remained in major molecular response beyond 18 months. And the time to lose the major molecular response was, not so rapid. So this is, of course, outside any guideline, but up to my personal perception of the type of problem, it's not impossible. Of course, you have one situation which is uncertain because this lady is sensitive, 7 years of nilotinib, but we have no reference to understand what really will go on in the following months. But at the same time, it is totally uncertain the time to conception. So we have two times. The first time to loss of response and the time to conception, both challenging because both totally unknown, because once more, this is the first pregnancy. On field, we have the strong desire of the lady and the family and of the husband. So at this point, which is the risk? The risk is that once stopping a TKI and they are looking for a pregnancy, the response is totally lost. So our program should be stopped because at that point, the priority is the life of the lady and not the desire of pregnancy not yet established. And is to monitor time by time. Of course, and IVF clinic for early conception. I have not experienced that, and but just to let more. I mean, an early onset of conception is an opportunity. But I have not experienced that. And interferon, once more, the data that we have, because we have data on that, there is a Brazilian study of 31 pregnancies, 16 of them were in major molecular response at the time of stopping the TKI, 8 received interferon, and 7 of them lost MMR as well. So these data are not, I mean, a big advertising to use interferon, but in any case, why not? Why not? We are in an experimental situation. The lady is not in a deep molecular response, and so having said that we have a limited information about interferon, having said that interferon generally requests weeks or months to exert biological activity, anyway, if the patient is sensitive, the disease of the patient is sensitive to interferon, once more, why not? We have no risk, 3 million megaunits a day to start, not higher dose, and then you evaluate. As this task, I believe, can be faced because the family is strongly has a strong desire to proceed, and at the end, the risk is that this plan will be stopped because the patient will lose rapidly the response. This is possible, of course, but it's not so. I mean, it's not the most probable situation. I have patients, they stopped after discontinuation, they lost the MMR, but they stayed in MR2 for 18 months, for 2 years even. So the kinetic is to be, you should evaluate the natural history of this lady stopping a TKI, and the expectation is can be good, of course. Can be good, of course. What is published? Sorry.
Does interferon delay conception?
Sorry, I missed the last sentence.
Does interferon delay conception, like if we start her on interferon now or wait till she gets pregnant and start it? Does interferon affect conception?
You know, using low dose, that is 3 megaunits a day or 3 megaunits 3 times a week, this should not affect the probability of conception, because the anti-proliferative effect of 3 megaunits 3 times a week is very low. Of course, high dose are not recommended. The only, I mean, you know, there is a published public experience. I believe I am a co-author to Patricia Holt on the Journal of Clinical Oncology in 2006, looked at the fate of patients who conceived when the disease was not in deep molecular response. And at the end, Stephanie, is it possible if I share my screen? Just 1 second. I really, You see, this is a very an old trial, but 2006. With patient, they were on imatinib since few months. Some of them with a longer time, all of them in complete hematological response, but only one in complete cytogenetic response. During pregnancy, they didn't receive treatment. No, and just one interferon. I have to, sorry, no, back. I have to change, okay, this one. And at the end of pregnancy, still some of them had a complete hematological response, some no, with a Philadelphia positivity in most bone marrow cells, but then the delivery, from delivery to start imatinib, a variable period of time, but at the last follow-up was registered only a blast transformation later on, but all many of the others had, you see, a good response or not worse with respect to the previous time. So this patient is 7 years on nilotinib, and I guess that our future from this point of view will be much better. You see, all this lady were no response and no complete cytogenetic response except one. I believe, Zeba, you can try. We have all the tools to face this case, keeping the safety of the patient, following the desire of the patient that is so important, without putting any risk. Not very good.
Okay, thank you.
We are all
Darlene?
so close to being out of time, and the questions come in when we run out of time. This always happens. But can I draw from a couple of questions that have been asked there in a general sense? What is your advice to male CML patients taking TKIs who are prospective fathers? How would you advise?
The advice is currently no problem to let them conceive a baby. Just one suggestion: if the potential father is above the age of 35 and 40 and received high dose, I mean, like they say, nilotinib 600 or imatinib 600 or whatever, of TKI for a long period, to check a specimen of the semen to see if the spermatozoa as number and the motility are good, because there were 15 years ago some publication suggesting that I mean, no issue because it's not mutagenic, any TKI is mutagenic, but some males had a low level and low motility of spermatozoa. So just in case of, but if the potential father is younger, of 30 years or less, generally it is not no problem to proceed with fathering. I have a patient that in the past he had seven babies, and in Italy is quite uncommon because we are along the denatality period, taking nilotinib 600 milligram daily. Then he was around 40 years of age, more or less, between 35 and 45.
Zeba, do you have a comment on that?
Yeah, we also documented 61 male pregnancies from male patients, and they were all normal. There was no major problem in that. And the reason I didn't present that was because since there's documentation that men whose wives get pregnant, they are fine. So I didn't put them in my paper right now, but it's been published. So
No.
in the same thing. So they're all fine. Then there's no problem. It's only the females who we are scared about what's happening, because the mother has to bring up the child, and fathers tend to marry again, and the child is lost.
Gianantonio, do you have a last comment?
No, my
Somewhat
last
less
comment
somber one, perhaps?
that I am grateful to you, Arlene, and to the CML Foundation for inviting me, because I really enjoyed this discussion with Zeba and other friends. Really amazing. I think that you did a very good work, and hopefully, I mean, with some help to, I mean, share perception. You know, we are being used to be, I mean, to consider reliable only what is published with statistical data, etc. But the real life is sometimes so different, and we should apply our knowledge to the situation that we have. Sometimes we cannot look at in PubMed and find all the answers. We can apply our knowledge, and in this field, this is particularly true, because the central problem is a couple with the desire of a baby. So we should do all our best, not saying to preserve our, no, okay, no, it is not possible, forget it. It's not the answer in any case. This is my last comment.
Thank you, Gianantonio. Great to finish on a positive note there. Thank you so much, Professor Gianantonio, Professor Zeba, Professor Meinolf, and Professor Namalia, for great discussions, and the audience for joining in. There are questions which have not been answered. I will get back to you with other comments. And yes, what a great discussion as always. And we hope to see you again. We're a bit out of time, but just to say this is the last in our series in South Asia, but let's get some feedback. Let's consider how the foundation can continue to best service physicians and researchers in South Asia. We really want to do what we can to be of best assistance. Again, if you are going to the India Cancer Congress, or if you live in Mumbai, please let us know. We'd love to see you there. We'd love to see you online too. And if you aren't already familiar with the Knowledge Centre, I'd strongly suggest that you check it out. There is literally a wealth of knowledge in there, including a dedicated pediatric CML module, which was co-chaired by Professor Sudop and Professor Muluk. It is excellent. There is also a pregnancy module, which is being rolled out as we speak. And many of the issues, questions, which have been raised today are also explored and dealt with there. So please, please, please go and have a look. And we add to it all the time. It's always changing. Please go back regularly and check. If you really want to keep up to date on what's new in CML, check out our website and please sign up for the ICMLF newsletter. If you do that, we can send you papers of the month and keep you up to date with upcoming meetings, webinars, links to summaries of conferences and discussions. You can also engage with our interactive case discussion forums, where we take difficult or interesting cases and take them out to the key experts in the field for advice or commentary. Or you might care to join our social media networks, Facebook, Instagram, Twitter, whichever you prefer to engage with. Okay, that's it from me. We're well and truly out of time. Thank you so much. It's been such a pleasure to participate in these sessions and share times and platforms with you all. Thank you very much.